Good morning. I think we'll go ahead and get started. Welcome, everyone. So prior to the talk this morning, I asked our speaker how I would correctly pronounce his name, and he said, it doesn't matter. Just say whatever you want to say. The correct pronunciation I would do wrong, so I will say what I think most people say, which is Dr. Renato Martins. Dr. Martins was born in Brazil, where he earned his MD before coming to the US to do residency at Gunderson Clinic in Wisconsin, followed by a fellowship in hematology oncology at MGH. He also spent some time in Boston getting his MPH at Harvard. He was then the chief of medical oncology at the Brazilian National Cancer Institute for 5 years, and he's been a professor in the Hemonc division here at UW since 2004. He is currently the Endowed Chair in Cancer Care, and he's also the medical director for thoracic, head and neck medical oncology at the SCCA. He does a lot of teaching. He's taught and lectured at dozens of CME courses, symposia, and oncology conferences. He mentors many oncology fellows. He's on a variety of organizations and committees. He has been on or is currently on multiple NCCN panels to develop oncology guidelines. And he has many research interests. He has ongoing grants pertaining to therapeutic interventions for head, neck, and lung cancers. And he has publications on thyroid, thymus, even skin solid tumors, as well as cognitive biases in oncology research. But his primary focus is on lung cancer. He's won awards for this research both in Brazil and here in the US. His talk today for us is entitled Letters from the Lung Cancer Battlefront. Please welcome Dr. Martins.
Well, that was I'm thankful, and this was a pretty impressive introduction. So if I were smart, I would pretend to faint, and that would be the end of this talk. So I would leave on a high note. So it's always kind of dangerous when you try to come up with a smart title for a talk. And I won't be going from letters from patients about their experience with lung cancer, although this lecture is permeated by specific patient stories, because I think that this is what it's all about. We're there to improve their lives, and I think that putting specific cases makes it very illustrative of what we do. So here, my conflict of interest, I think it was displayed before that I have lots of grants, but they all go to the University of Washington, so I really have no stake on them. Let me start you with the first case. This is a 66-year-old male former smoker that presented with stage 4 adenocarcinoma of the lung with metastatic disease to bone. Started therapy with cisplatin and etoposide and had disease progression after 4 cycles of palliative chemotherapy. He unfortunately had some deterioration of his functional capacity, and with that did not receive any additional cancer-specific therapy and died 5 months after his diagnosis. This was the first patient I saw with lung cancer during my fellowship in 1995. So that brings the question of now transporting to 2013, what is the median survival of patients with metastatic non-small cell lung cancer treated? And we don't have one of those response systems here. So I would ask you to choose one of these options and try to keep in your mind what it is. And the correct answer is that this question is not applicable anymore. In fact, when I receive a MedCon call and someone is describing a case of someone with stage 4 lung cancer, it takes a while for me to start to make up my mind. And I think that hopefully I will explain why that is during this talk. So here are the letters, EGFR, ALK, ROS1, and the story of PD1 and PDL1. And if you have not been following closely the lung cancer history, I think you will see that it has changed dramatically over the last few years. So let's start with the EGFR. So EGFR, it was postulated as being a potential target for anti-cancer therapy since the mid-1980s. As you can see, there are 4 members of the HER family. The other very well-known member of this family is HER2, which is a target in breast cancer therapy. Interestingly, I don't think I have a pointer, but interestingly, the members of the family can dimerize with each other, and that leads to different signals. So there is a potential theoretical advantage of using not one inhibitor of a single member of the family, but an inhibitor that will inhibit all members of the family. And as you can see, going down the PI3 kinase pathway or the RAS pathway, it is associated with cell proliferation, cell survival. So that's why it is a target for anti-cancer therapy, or at least postulated to be. You know, when you get older, for the residents and fellows, it's always interesting to give a little perspective of how we got where we are. And this is the first publication of phase 1 clinical trials of a drug called gefitinib, which is an oral tyrosine kinase inhibitor of EGFR. You know, traditionally, in fact, when I was in fellowship between 95 and 98, we had one member of the staff of MGH that thought that enrollment in phase 1 clinical trial was unethical. Because, you know, although we explained to patients that the primary objective of the study is to identify the toxicity and tolerance of the doses, what the patients really want is a benefit. And if you look at the benefit of phase 1 clinical trials during the 1980s and 90s, the chance of a meaningful benefit was in the 1 to 2% range. Then we had a drug like gefitinib. And here you have a patient that was on pre-treatment with obviously a very large tumor with collapse and pleural effusion. And 2 months after therapy, a substantial improvement, and after 3 months on therapy, almost a complete resolution of the tumor. And you really had never seen that before, particularly in a phase 1 clinical trial. So there was an enormous amount of excitement with a drug like that. In fact, gefitinib was developed by a drug company called AstraZeneca, which is the same one that made tamoxifen, which obviously had a huge impact on the care of breast cancer patients. And they thought that gefitinib would be the tamoxifen of solid tumors. That's how they were advertising the drug. That led the 2 drug companies that were developing OR inhibitors to embark in similar trials. Both of them had trials in Europe and the US at the same time with very similar chemotherapies, combining with their OR inhibitors, with the idea that by adding that to chemotherapy in first line, it would lead to a significant improvement in the outcome. This is a sort of an unique scenario because these phase 3 trials were launched before any meaningful phase 2 data was available. There was so much excitement with the phase 1 data that they immediately embarked into committing close to 5,000 patients in phase 3 clinical trials, all with the same design, chemo plus minus, I guess that's okay, combining an oral tyrosine kinase inhibitor of EGFR with conventional chemotherapy. And I would say that 9 out of 10 lung cancer experts were absolutely convinced that these trials would be positive. And speaking to the quality of lung cancer experts like myself, here you have the results. As you can see, there was absolutely 0 survival benefit with adding an EGFR inhibitor to chemotherapy in the first line setting. There wasn't even a signal of benefit in these 4 trials that were presented and published almost at the same time. Then Canadians to the rescue. They had, as they normally do, a much more pragmatic approach to this question. So this is the NCI Canada-led study. As a side note, when we published this at the New England Journal of Medicine, there were a significant number of patients from Brazil. And if you're interested, the picture there is the NCI, which is in Rio. So here's the design of their very pragmatic trial. You have patients that have received 1 or 2 prior lines of chemotherapy for non-small cell lung cancer, and they were randomized to receive erlotinib, an OR inhibitor of EGFR, or placebo. The primary objective of the study was survival, and in fact, you could follow the patients with a chest X-ray if you wanted. They really wanted to know, do people live longer or not if they were treated with one of these agents. The response rate of erlotinib was 9%, so the response rate was pretty low. But as you can see, there was a difference in patients that achieved a stable disease. When we talk about response rate in evaluation in clinical trials, we have to remember that it is considered stable disease if someone has a 19% increase on the volume of tumor, as well as 29% decrease. Those are both called stable disease. If someone has a 30% decrease, now that's called response, and I think it would be hard to advocate that there is a difference between a 29% shrinkage of tumor and a 30% shrinkage of tumor. So this stable disease is a mixed bag of outcomes. But the reason that this got published at the New England Journal of Medicine and actually led to the approval of the drug was that it led to a survival improvement in patients treated with the erlotinib. The median survival with placebo was 4.7 months. The median survival with erlotinib was 6.7 months for an absolute difference of 2 months. And if you don't follow the literature in lung cancer, 2 months is actually a pretty impressive benefit. But perhaps more significant was an absolute difference of 10% in the chances of surviving after 1 year on therapy. This benefit was seen across, in this forest plot, was seen across most subgroups one would want to look at. But I want to point out the issue of never smokers there. As you can see, they had a very substantial improvement of their outcome if they did not have a smoking history. So, there were a lot of studies looking at how can we identify the patients that have a great response, and we look at IHC expression of EGFR. We look at FISH based perhaps on the experience coming from HER2, and it's just one of those things. One day the Boston Globe published a history of a woman in her 30s with small kids who had stage 4 lung cancer and was treated with gefitinib in the context of a clinical trial and had achieved an almost complete response and was doing quite well. Then Dan Haber called Tom Lynch at home on Sunday. This was published on the Sunday issue of the Boston Globe, and said, well, why is that? Why does she have such a great response? And he said, well, we don't know. We've looked at this, we look at that, and no one really knows. I said, oh, there got to be a reason. Do you guys have tissue on patients that have such a good response? Which then connects to the issue of tissue banking and how important that is. So they actually had frozen tissue on 9 patients that had a great response to oral inhibitors of EGFR. And in 8 of them, they found mutations on the tyrosine kinase domain of the receptor, which led to hyperactive and hypersensitive receptors to EGFR. So these activating mutations, and there are 2 of them that represent about 90%. One is on exon 21, L858R, and then you have deletions on exon 19. are much more prevalent in patients that do not have a significant smoking history. And that then ties to why patients on that randomized trial that were non-smokers seem to have a much better outcome than others. So, what is the chance of having an activating EGFR mutation if you have lung cancer? So, if you look at patients of Asian descent with adenocarcinoma that are non or light smokers, which we define as less than a 10-pack year history, it's a 60% chance of having an activating EGFR mutation. We're going to go back to this trial in just a minute. In the US, we did the first trial together with MGH of first-line therapy with an EGFR inhibitor in patients with non-small cell lung cancer. And the inclusion criteria of that study was Asian descent or adenocarcinoma or female or non-smoker, and the chance there was 35% of our patients tested had an EGFR mutation. If you look at data from Spain, patients that were former smokers, and that was not adequately defined in the New England Journal of Medicine paper, the chance was 10%. And if you're current smokers, the chance was 6%. But perhaps more informative is this data from MR Sloan Kettering, where they actually look at the tobacco burden and the chance of having an EGFR mutation. And as you can see, it goes down pretty quickly, from 52% if you're a never smoker to if you have more than a 75-pack year, it's about 4%. So if someone has a EGFR mutation and they are treated in first line, what do phase 2 clinical trials tell us that the outcome is? So we're going back to that trial that we did together with MGH, and we included 31 patients with an EGFR mutation. They were treated with gefitinib, and we observed a response rate of 55%. The progression-free survival, so remember, this is progression-free survival. This is not overall survival. When I was in training and fellowship, the median survival of treated lung cancer was 8 months. Now we're talking about progression-free survival. So that survival without evidence of disease progression was 9 months, and the overall survival was 17 months. Data from Japan, 28 patients treated also with gefitinib, response rate 75%. Progression-free survival of 11.5 months, and they did not report their overall survival. And now we're going back to this phase 2 trial published in at the New England Journal of Medicine from Spain, a very large trial. Patients treated with erlotinib, they had a 70% response rate, a 14-month progression-free survival, and an overall survival of 28 months. So that led to a number of randomized trials looking at the same question. Is it better to treat patients with an EGFR inhibitor, or is it better to treat them with chemotherapy if they do have an EGFR mutation? In this case, they actually did not select for an EGFR mutation. They select for clinical characteristics, and that gave very interesting results. So this trial was done in Asia. As it turns out, 89% of the patients included in this study were female, and they have a higher rate of EGFR mutation than males do. And they had to be either non-smokers or have less than a 10-pack year smoking history. And the outcome was completely dependent on the presence of an EGFR mutation. So let's look first to the curve C, where you have patients that are EGFR mutation negative. As you can see there, they did a lot better if they got treated with chemotherapy. The progression-free survival was far better with chemo. But conversely, patients that had an EGFR mutation, that's curve B, had a much better outcome if they were treated with an EGFR inhibitor than if they were treated with chemotherapy, which in that trial showed then that clinical characteristics are not enough. You really have to know the EGFR mutation status to properly select someone's treatment. Patients in this trial treated with an oral tyrosine kinase inhibitor had better quality of life, as one would predict. Although these agents clearly have toxicities, the main ones being diarrhea and an acneiform type of rash, on average, these are much better tolerated than conventional chemotherapy, and here you have the data on quality of life. So this is a work presented at ASCO a couple years ago, and in this case, patients were selected based on the presence of these two more common activating mutations of EGFR. So not clinical characteristics anymore. You had to have an EGFR mutation to be included in this trial. And they were then randomized to receive platinum-based chemotherapy or erlotinib. And just like we saw in the Asian study, the progression-free survival with erlotinib was far better than with chemotherapy. That then this trial has led to the approval of erlotinib as a first-line therapy for patients with an activating EGFR mutation. And it's currently the standard of care. Overall survival, like in all these trials, has not been impacted, and we believe that that is a consequence of crossover. So as these drugs are available, patients that are randomized to receive chemotherapy, when they have evidence of disease progression, they are then treated with erlotinib in second and third line, and they end up having the same benefit. So going back to another case, are there patients who should be treated without performing an EGFR mutation analysis? And the answer is yes. So this is a case of a 79-year-old Filipino man that presented with increasing shortness of breath that brought him to the emergency room. A chest X-ray showed a large left pleural effusion. A CT confirmed that, as well as extensive pleural nodularity. And paracentesis show malignant cells compatible with adenocarcinoma. I review my note and I grade his functional capacity as a 3, which means that you're spending more than 50% of your time in bed or chair. I think I was profoundly optimistic or perhaps embarrassed of treating him. His performance status was probably a 4, which means that he needed help to go to the bathroom. He was on a wheelchair on oxygen, which is always a bad sign when you walk into an oncology office. So here's his initial CT scan, and as you can see, his left hemithorax is almost completely replaced by either fluid or tumor, and that's 4 months later. So this is truly a case of a patient being resurrected from the dead by an oral EGFR inhibitor. This patient actually lived for 4 years with stage 4 lung cancer. Very functional, went back to the Philippines, did some business down there, had some property that had been stolen, and he was trying to get that back. So he really had a pretty good quality of life during most of that time. And at one point, I confess that I even treated him with chemotherapy at age 81, and he responded pretty well to that too. The reason that this patient does not need EGFR is obviously he did not have a significant smoking history. He is of Asian descent, and there was no choice between chemotherapy and an oral EGFR inhibitor. The choice was hospice or an oral EGFR inhibitor. Giving him chemotherapy on a wheelchair on oxygen would be malpractice. So we should not do that. Moving on to another group of letters, that's the anaplastic lymphoma kinase. And as you can see here, this transmembrane protein, as I understand it, without an identified ligand at this point, most of the time is translocated into EML4, leading to a fusion protein that is hyperactive and leading to a number of downstream signals of cell survival and proliferation. In fact, some of the same pathways that you saw with EGFR. That is a less common molecular abnormality in lung cancer. It's present in about 4% of patients with non-small cell lung cancer. And the vast majority of patients, just like with EGFR, do not have a significant smoking history. And in fact, with ALK, that may be even more significant than with EGFR. I will be presenting to you 2 phase 1 clinical trials published at the New England Journal of Medicine. That is extremely unusual. Here's the first one. So this is a phase 1 clinical trial of crizotinib, an ALK inhibitor, in patients with non-small cell lung cancer presenting with an ALK rearrangement. And this is what's called a waterfall plot. Each one of these bars represents the amount of tumor shrinkage seen in an individual patient. And as you can see here, the vast majority of patients have a very significant improvement in their tumor burden on this phase 1 clinical trial. And you have a example from the New England Journal of Medicine publication as well. Interestingly, crizotinib was developed as a MET inhibitor, and they did the phase 1 clinical trial and start to find that all the patients that were responding did not have MET amplification as they predicted. So they then went looking for, what other molecular abnormalities were present, and they really stumbled into this ALK issue. This is a trial that has been published at the New England Journal of Medicine. It's a randomized phase 3 study that would be extremely hard to do in the U.S. This is a randomized trial between crizotinib in second line versus chemotherapy. And as one would predict, and that's why it would be hard to accrue to this trial in the U.S., patients with an ALK rearrangement had a very significant improvement in their outcome versus conventional chemotherapy. And both in first and second line, that is clearly the standard of care for patients with an ALK rearrangement. So now another case. This was someone I saw in 2009, 46-year-old male never smoker, retired Microsoft executive, presented with some hemopsis and was found to have a large left lower lobe mass with involvement of mediastinal lymph node by PET scan, and a biopsy showed an adenocarcinoma. He received 3 cycles of neoadjuvant chemotherapy with the plan of then going to surgery. And although he did have some response to the chemotherapy, unfortunately, at the time of surgery, he still had positive mediastinal nodes. And if surgery were to be performed, it would require a left pneumonectomy, reason why the surgical procedure was then aborted. Well, he still had localized disease, so then we proceed to treat him with a combination of chemo and radiation therapy, still with a curative intent. And unfortunately, he had a very aggressive disease. Within 2 months of completion of chemo radiation, he already had evidence of disease progression. We tested him for the presence of an EGFR mutation that came back negative, and he was the first patient we tested for an ALK translocation. In fact, I had to ask as a personal favor at MGH for his tumor to be tested because they were not testing patients that were not in their system. I'm showing his picture because he has been incredibly open about his story. He has been in the news, and he was very symptomatic with shortness of breath and cough. And he tells me that within 48 hours of starting on crizotinib, after he was found to be ALK positive, his symptoms had markedly improved. He's still doing extremely well based on this experience. He thought that he should give it back to the community and actually ran for the Washington Senate and was elected. And he is the chair of the Ways and Means Committee in the Senate, and you know that the people that control the purse. So he has been very busy. So where are we with the ALK story? There are now second-generation ALK inhibitors. We still have not found a good second-generation EGFR inhibitors, but we already have promising second-generation ALK inhibitors. This is a phase 1/2 clinical trial that was presented at ASCO this year, and in fact, that publication has now been submitted to New England Journal of Medicine, and Laura Chow from our group is one of the authors of that submission. This is 123 non-small cell lung cancer patients with an ALK positive. Were treated with the second generation inhibitor called LDK378. It is a little bit more toxic than crizotinib. It has some problems with elevations of transaminases as well as diarrhea. 88 patients evaluable for response, and the response rate was a whopping 70%. So 70% of patients have significant tumor shrinkage, despite the fact that they were now having evidence of growth while on crizotinib. 64% had crizotinib-resistant disease, 73% response rate. The median duration of response is 7.4 months, and there were responses seen in untreated brain metastasis, which is quite interesting because that is a common site of failure of crizotinib. So now moving on to another series of letters. This is ROS1. It's a tyrosine kinase member of the insulin receptor family. Chromosomal rearrangements were initially describing glioblastoma. It's present in about 2% of non-small cell lung cancer cases, so grossly half of the prevalence of ALK. And it is more common in younger and never smokers, and they do respond to crizotinib as well. So here's another case of a 62-year-old male with a history of progressive shortness of breath, with physical activity and a persistent dry cough. Had an abnormal chest X-ray and CT, bilateral lung infiltrates, had a bronchoscopy which showed adenocarcinoma. He was found to be EGFR ALK negative, and he was the first patient we tested for the presence of a ROS rearrangement. While we were waiting for the results, he was actually started on chemotherapy and had a minor response after one cycle with some improvement of his symptoms, but then we got the results of ROS1 being positive. In fact, ROS1 positivity is uncommon enough that at that time, and now we do it here, as you'll see, but at that time was being done in University of Colorado only. And the pathologist was so excited that she paged me because he was positive. He was started on crizotinib, and as you can see on presentation, he had bilateral lung disease, and he has had a very substantial improvement. Two interesting side stories about this patient. He is a sheriff in King County, and I've never seen so many guns inside of a examining room the first time I saw him. I said, well, I think I need to examine you now, and then he started pile. There was even a big knife as well. The second thing is that I was at a Railroad Earth concert at Chateau Saint-Michel, and he was doing security over there. So he came in and talked to me, and we had a good time. And then I sat down, and a guy came in and sat really, really close to me. So my wife is sitting there and absolutely convinced of two things. One, the guy doesn't see very well, and two, he's probably going to hit on me at any minute. So he comes close to my ear and says, "Is everything okay?" And I say, "Yes, why?" "Well, the police was talking to you." I said, "No, we're friends." And he's like, "Oh." And then he went to whatever he was doing. So a little on histology. So EGFR activating mutations as well as ALK and ROS1 rearrangements are not seen in patients that have pure squamous cell carcinoma. So someone with a pure squamous cell carcinoma histology, we actually don't test them for these alterations. If one does testing in a sequential fashion, it's important to remember that the 100% and the percentages will change as you accumulate more and more information. So this is a pie chart of the incidence of EGFR and ALK in patients that are light and never smokers. There, the ROS1 positivity is in the 4% range. However, if you already know that someone is EGFR and ALK negative, well, the 100% now exclude those patients. And the positivity of ROS is close to 8% in that case. So, you may think that 2% is too low, but as you accumulate information, that percentage starts to go up just because you're not including patients that you already know the results. So one of the most important developments for the University of Washington is the Oncoplex testing. Now, I don't know how much you know about it, but this is a huge deal for us. And I'll explain that in due time. Currently, when this slide was made, Oncoplex tested for point mutations, rearrangements, and copy number of 194 different genes associated with either cancer development or pharmacogenomics. And I should give enormous credit to our lab medicine partners. Colin Pritchard and John Tate have been absolutely terrific on the development of this. Here's the updated data of Oncoplex testing at the University of Washington. As you can see here, lung cancer is about a third of patients tested. And there you have the genetic abnormalities that were detected in all patients, not lung cancer only. So as of now, we are slightly above 100 patients from whom we have a genetic profile that includes 194 to 200 possible genetic abnormalities, which is just phenomenal. Not only because we can do a lot of the testing in-house, but some patients, let's use EGFR as an example, will have disease control despite the fact that they have an exon 19 deletion for 4 months, and others will have control for 2 years. And obviously, there are other genetic traits that will determine that. That's not kind of a luck type of phenomena. So here's how we approach molecular testing at the UW and SCCA. If we have a patient that has advanced non-small cell lung cancer that have a non-squamous histology, irrespective of their smoking history, and that, by the way, is the recommendation from NCCN and ASCO as well, which is our professional organization for medical oncology. Patients are tested for EGFR and ALK. That has a 5-day turnaround time. And if they're positive, they're treated with erlotinib or crizotinib, respectively. But if they're negative, then they got ROS1 testing in the context of Oncoplex, and that has a 6-week turnaround time. But our colleagues in lab medicine are doing all they can to shrink this down. So if someone has a result on Oncoplex that shows a HER2 abnormality, there are drugs that can be used. Afatinib is approved for first-line therapy in non-small cell lung cancer. It's a pan-HER inhibitor, so there may be a potential advantage there. BRAF, there are 2 drugs that are approved for melanoma. MET amplification, crizotinib, remember, was initially a MET inhibitor. ROS1, crizotinib, RET fusion, a drug approved for medullary carcinoma of the thyroid. And PI3 kinase and KRAS, we can refer patients for clinical trials. The reason that this is really important is some of these genetic abnormalities are in the 1% to 2% range. So we had a trial that is now closed of a BRAF inhibitor in non-small cell lung cancer. We would never have been able to open that trial if we did not have Oncoplex. Because it's impossible to imagine that we would test 100 patients to get one into a clinical trial. No clinical trial could be done like that. But now we know who has a BRAF mutation based on our Oncoplex data. So when we open a clinical trial, we can go after the 4 or 5 patients that have that abnormality. And I want to conclude about something that is absolutely phenomenal, and that's the PD-1, PD-L1 story. So the programmed DAFT1 receptor was first identified in T cells undergoing cell death, and I'm not an immunologist, so now I'm more walking in very thin ice. PD-1 is expressed within 24 hours of T cell stimulation. And PD-1 and PD-L1 are expressed in many tissues in high levels in lung, heart, and liver. And PD-1 deficient mice develop autoimmune diseases. So, if you prefer a cartoon, PD-1 and PD-L1, as well as PD-L2, are both associated with suppression of T cell after they've been stimulated. So these are 2 phase 1 clinical trials that were published at New England Journal of Medicine last year. This one has 5 authors from the University of Washington, including the first co-author, as well as 3 members from our lung cancer group. This is a phase 1 dose-finding trial of a PD-L1 antibody. And as you can see here, or maybe you can't, the other day I was looking at the screen. I brought my glasses with me. I was looking at the screen, and I realized that I can't read any of that anymore, which is sort of sad. So as you can see, the treatment is extremely well tolerated. If you look at the response rate in patients with non-small cell lung cancer, it's around 20%. This is a spider plot, something that I had never seen before. They circulate this to the authors. Apparently, it's common in the immune-mediated therapies. And that's because there may be some bulging of tumor initially, supposedly due to an inflammatory attack by the immune system. But what I find most interesting about this spider plot is with chemotherapy, usually you have a pretty significant shrinkage of tumor, and then you have stable disease. But what we've seen with these agents is that sometimes, and these 2 curves in the bottom there show that, sometimes with these agents you have some shrinkage, further shrinkage, and keeps getting smaller, sometimes over a period of a year or more, which is quite impressive. So this is from the New England Journal of Medicine publication. In the bottom, you have a patient with liver metastasis. That's actually a patient of ours, of Laura Chow. And as you can see here, the patient had an amazing tumor shrinkage with a PD-L1 antibody. The same issue of the New England Journal of Medicine, now a PD-1 antibody. And I want to make this point. So PD-1 can interact with PD-L1 or can interact with PD-L2. And there's quite a bit of PD-L2 in lung. In fact, PD-1 deficient mice can develop a pretty significant lung inflammatory process. So although there is the theoretical benefit of inhibiting PD-1 because it would become sort of independent of the expression of PD-L1 by the tumor, there is the risk that you would trigger then a pretty significant inflammatory reaction in the lung. And so far, it seems that that is the case. So although it's a rare phenomena, it seems that in somewhere between 3 to 5% of patients, there is a significant pneumonitis associated with therapy. So in conclusion, patients do respond to PD-1 and PD-L1. These responses are seen in both squamous and non-squamous carcinoma. In fact, everything that I showed you before shows better outcomes in patients with non-squamous histology. As it turns out, patients with squamous histology seem to do better with PD-1, PD-L1 inhibition. PD-1 antibodies may be associated with more pneumonitis, and responses we're still struggling to find out why the response rate is 20% and what determines that, but responses may be higher in tumors that express PD-L1. This is recent data from presented last week at the European Cancer Conference. This is 85 patients with non-small cell lung cancer treated in a phase 1 clinical trial. The median time to first response was 11.9 weeks. So, in fact, it takes a while for patients to be classified as responders. And some of the responses are very long-lasting. As you can see here, the shortest was actually 170 days, which is pretty impressive. But they saw responses that were as long as 534 days. The response rate in non-smokers was 10%, and got a lot of press last week. The response rate in former or current smokers seems to be more than twice as high. So, do lung cancers associated with smoking are more immunogenic? And do they respond better to one of these strategies? I think that's what we're going to find out. So I want to conclude with another case. This is a 68-year-old female current smoker presented with a mass in her left lower leg, had a biopsy of that, which showed a poorly differentiated adenocarcinoma. Staging showed a right lung mass, adrenal, a brain metastasis. She was treated with gamma knife for her brain metastasis. And she had a performance status of 2, which is less than 50% of your waking hours in bed or chair because of fatigue. And she started on chemotherapy and had progressive disease after 2 cycles. So basically chemotherapy refractory. She was enrolled in a randomized clinical trial between docetaxel, conventional chemotherapy, or this is actually incorrect, it's a PD-1 antibody. And she was randomized to the PD-1 antibody. And if you're not accustomed to see adrenal metastasis, here is one, and it's fairly large. So this is March 28th, 2013, and that's her CT from last week, where the adrenal gland is pretty much gone. This patient has gained 10 kilos since she started on therapy. She also tried to stop smoking, so she said that she's eating a lot of cake. But she has an excellent quality of life, and she's doing everything with her family, and this is what it's all about. She has had an incredible turnaround. And when I have to review all the possible side effects of the medication, she turns to me and says, "Doc, I feel nothing. I can't come up with any side effects from it." So now we have a therapy for stage 4 lung cancer, which some patients are telling us that they feel nothing from. So what's next? We have second generation EGFR inhibitors. The Cotinib is a pan-HER inhibitor that had a progression-free survival of 17 months in a phase 2 clinical trial. We're putting together the manuscript for that. Radiant trial, Keith Eaton is the PI for the University of Washington. That's a trial with 1,200 patients randomized between adjuvant, so after surgery, erlotinib, or placebo. Tissue is collected in this trial, and I'm particularly interested in the outcome of patients with an EGFR mutation. If we do deliver this therapy in the adjuvant setting, we will prevent the disease from coming back, period. And then we have multiple clinical trials exploring the PD-1 and PD-L1 pathway. These are the trials that we have here at the University of Washington. That's actually an incomplete list. When I came here in 2004, I was the medical director of thoracic and head and neck medical oncology, which meant that I was the medical director of myself. I was the only person doing it. And our group has grown tremendously. I have to make a special mention about Keith, who is a very, very dear friend, who had, some of you know, a very tough year. And I am glad to report that he's doing terrific. And I put the picture of our research staff who are incredibly committed to getting patients in clinical trials so they can be helped by these therapies. So thank you, and I save 5 minutes for questions.
Very nice work. It's terrific, and I've been pleased to follow it, mostly in the New England Journal. In other articles in the New England Journal, it looks like tumors evolve.
Mm-hmm.
And so I'm wondering what you're seeing in the lung cancer tumors, and are some of these mutations just some metastases?
So that's about a 25-minute answer, but I will try to shrink it in a minute or less. So there is a specific mutation. Let's use EGFR as an example, called T790M. And for someone that's very simple-minded like myself, you have the tyrosine kinase groove, and then you have a T790M mutation. This is a drug, let's say erlotinib. You have a T790M mutation. Now the groove is like this, and erlotinib doesn't get in anymore. We always call those acquired mutations. However, work from MGH showed that if you look at circulating cancer cells, it is likely that these are present from the beginning, and they are really not acquired. The amount of time that someone will have benefit from erlotinib, for example, is directly dependent on what percentage these cells are. And actually, that work from MGH showed that when patients had those cells from the beginning, they had a much shorter time to disease progression. So yes, we're trying to figure out inhibitors that will inhibit EGFR even in that context, but so far we have not been very successful. Yeah. I'll take it.
I was going to ask the other side of that question. How often do you see these mutations in benign, proliferative, or inflammatory lesions?
Supposedly never. I mean, obviously, those are all somatic mutations. So obviously, I learned that by discussing with people that are smarter than I am, and they tell me that if those were germline mutations, would probably be incompatible with development. Although there is one report of a T790M germline mutation from a Japanese family. We do have here a patient that was, in fact, she was the first patient we diagnosed with an EGFR mutation. And in fact, when I was I didn't want to include her case for a number of reasons. But when I was putting this talk together, I realized that every patient that I tested first for something had an incredible response. And I don't know what that is, but she had a tremendous response. She had an EGFR mutation, had a tremendous response. And when I collected her family history, she said, yeah, my brother died of lung cancer. And like me, he didn't have a significant smoking history. He was 37 years old. He was actually a rower for the U.S. team. And that was just strange to have two family members that did not have a significant smoking history, both developing lung cancer. So I said, well, where did he die? And she said, he died at Swedish. I said, okay, can we get permission to see if his tumor is available? And she said, yeah, I think he had an autopsy. So we got permission. We contacted Swedish, and we got the blocks from the autopsy. She had an exon 19 deletion. He had an exon 19 deletion. And both, we tried to select as much as possible normal tissue. In her case, it was easy. It was just get a blood draw. In his case, we tried tried to look at areas that did not have tumor and tested for it to see if it was a germline mutation. And again, that's how I learned that germline mutations would probably be incompatible with normal development. And neither of them seem to have a germline mutation. But then the question is, are there something on the germline that will determine that you will develop these somatic mutations? And that's what we don't know. So if any of you have a brilliant idea of how to look at that question, we still have the blocks with us. And I find hard to imagine that this is a coincidence.